हेलो टू ऑल। हाँ बस हो गया कनेक्शन। हाँ हाँ सर, सर का लगा दे सर। आ रहे सर, सर का ही लगा दे इसमें। हाँ सर बिल्कुल बिल्कुल सर। चलो सो वी आर स्टार्टिंग इन अ मिनट और टू। ओके सो स्टार्टिंग सून, जस्ट अ मिनट और टू। ओके सर इज हियर विद मी। चलो पारस दिख रहा है? So I think we all are visible to all of you. Okay. So इसमें वो शुरू हम वो ओपन कर देते हैं ना टेलीग्राम से लिंक इसमें। We'll open here and we can watch it here. क्योंकि पिन किया हुआ है मैसेज में। ये देखो ना आपका। अच्छा कि उसमें टेलीग्राम पे आएगा अलग से। नहीं यहाँ पे पिन किया हुआ है, ये आपका ये मैसेज। आपका वाला सबसे नीचे। ऊपर पिन वाला खोल लो ना। इसमें खोलेंगे ना, इसमें पिन है ना। ये रहा। हाँ वही पिन है। तो यहाँ पे हम चैट देखेंगे। हाँ तो so we are having Dr. NITIN with us, okay, and he'll be taking your thyroid and most of the systemic surgery topics. Yesterday I took shock सर, तो मैंने कल शॉक करा दिया था इनका, तो मेडिसिन सर्जरी इंटीग्रेटेड है। अब आज अब थायराइड करा देना इनको सर इस तरह से कि दे शुड बी एबल टू डू इट इन सच अ मैनर कि मैक्सिमम 80% कवर भी हो जाए, बट शुड नॉट बी वेरी हैक्टिक। वरना सर थायराइड 3-4 घंटे का है, अपना टारगेट क्या है उसको कंसाइज करना है, ठीक है ना। तो सर विल बी टेकिंग द सेशन एंड सर विल बी इंटरेक्टिंग। तो जो भी आपको इश्यू आता है, एनीथिंग आती है, यू शुड बी एबल टू इंटरेक्ट विद सर, ठीक है। बाकी शुरू करने से पहले पारस वापस आ गया, ही वाज नॉट वेल। पारस एक गाना सुना दे सर, बैठ सर।
अच्छा बैठिए ना। अच्छा दोनों बैठेंगे, मेरा भार नहीं ले पाएंगे। आप मेरा भार नहीं ले पाएंगे।
आप अपनी जगह
आप अपनी जगह पे आइए।
थैंक यू सर। ना ना जी आप अरे पर एक चेयर और ले लीजिए।
हेलो यारो, कैसे हो? क्या इतनी प्यारी वाली दुआएं दी हैं कि मेरा प्लेटलेट काउंट आज 1.5 लाख पहुंच गया और पहुंचते ही मैं बाहर। क्या सुनोगे बताओ, क्या सुनोगे? क्या
इंग्लिश? डोंट वरी, इट विल बी इन इंग्लिश, डोंट वरी अबाउट दैट। ओके
क्या उस चांद को गुरूर है, उसके पास नूर है। उस चांद को गुरूर है, उसके पास नूर है, पर उसे क्या पता हमारे एफएमजीज को ही नूर है। क्या बात है। एक और बढ़िया सी है।
शेर भाई सुनो।
उन्होंने क्या, इश्क के दरिया में हम भी डूब कर देख आए। इश्क के दरिया में हम भी डूब कर देख आए, वो लोग ही समझदार निकले जो किनारे से लौट आए। तो कौन कौन है इश्क में? कौन कौन है भाई बताओ। इश्क में कौन कौन है? मैं इश्क में पागल, ओ मैं इश्क में पागल। क्या बात है, क्या बात है। बताओ, है तो नहीं कोई इश्क में? किनारे से लौट आना।
यस
ठीक है।
कहते हैं ये क्या है, आग का क्या है ये, इश्क नहीं आसा, एक आग का दरिया है और डूब के जाना,
नाचते हो जाना उसमें से। क्योंकि इश्क वाले दरिया से जब जो चला जाओगे तो फिर वो बेकार ही हो जाएगा।
यस
सर आपको हुआ कभी इश्क हुआ?
रैप का पूछ रहे हैं।
अच्छा रैप कर दो,
रैप कर दो।
रैप सुना दे कोई।
रैप कौन सा रैप सुना दे भाई?
ओ ई वाला एक मत RAP।
नितिन सर आपको हुई है मोहब्बत?
बड़ी बात,
बड़ी बात। आशीष सर आपको तो रोज होती है। ठीक है। तुम आए तो आया मुझे याद, गली में आ चांद निकला, जाने कितने दिनों के बाद गली में आ चांद निकला, जाने कितने दिनों के बाद गली में आ चांद निकला, गली में आज लड़कियां दिखी। क्योंकि मैं बहुत दिनों बाद बाहर आया।
सोनू मेरी डार्लिंग भाई, फेस ऑफ NLC।
क्या बात है, क्या बात है।
चल ये कह रहा है ये गाना अच्छा नहीं है,
अच्छा नहीं, कौन सा वाला सुनोगे भाई?
अच्छे नहीं, सारे गाने अच्छे हैं।
सारे बताओ कौन सा सुनोगे?
हनी सिंह। चलो।
माए निमाए शिमले दिराए, चंबा कितनी गुदू, शिमले विवसना कसोली विवसना, शिमले विवसना कसोली विवसना, चंबा कितनी गुदूर है। सही है, मजे हैं, मौज है, मजे हैं, मजे। लौंडो फैजान आ गया, अपना पास हो गया, फिर भी आ गया, देख लो। इंद्रजीत भी आया है। क्या बात है, पुराने यार आ गए हमारे। क्या बात है, अभी माहौल बनाना है, थायराइड पढ़ाएंगे आज सर।
बिल्कुल।
तो आज
थायराइड के सारे क्वेश्चन, कम से कम 2 से 3 क्वेश्चन,
2 से 3 क्वेश्चन आने वाले हैं। अरे इंग्लिश हिंदी लड़ते रहते हो यार, क्या यार।
अरे टीचिंग इज इन इंग्लिश,
यस, बकचोदी बकचोदी शुड बी इन हिंदी ओनली, ठीक है, मजा नहीं आता।
बचपन का प्यार,
बचपन का प्यार,
बचपन का प्यार नहीं, एफएमजी की
बचपन में
नंबर बहुत पास।
सुन लो मेरी जाने मन, पढ़ते रहो बस, ठीक है। ये क्या है, हाँ खाता मैं तेरे, क्या है रे, रहने दो, तुम बने हो बेदाग, मुझे दागदार ही रहने दो। क्या बात है, आई विल पास। तो एक बारी जोर से भाई, ये मेरे आधे जो है ना हवा में है, तो मैं खड़ा ही हो जाता हूँ यार मैं यहाँ खड़ा हो रहा हूँ। तो याद रखना, हर दिन 10 बार कम से कम भी क्या बोलना है, आई विल पास, 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 ठीक है। ये हमेशा मंत्र याद रखना है, आधी चीजें कॉन्फिडेंस से भी सॉल्व हो जाती हैं, समझ गए। बस ये मंत्र याद रखना, और जो लोग दिल्ली आने वाले हैं वो मिलना जरूर, उनको फिर सीक्रेट वाला दिया जाएगा, समझ गए। क्या बात है, क्या क्या लिख दिया है इसने,
बातें लिख रहा है कोई हाइड कर रहा हूं भाई, ये बड़ी जिंदगी बड़ी बात है भाई। ये देखो पता नहीं क्या लिखा है,
क्या
किसका जिक्र था
बहुत सारे लिख दिए इसने तो। किस,
सॉरी भाई छुपाना पड़ गया।
आई विल पास, क्या बात है। सब लोग एक एक बारी, सब लोग शुरू होने से पहले आई विल पास, आई वॉन्ट ऑल ऑफ यू टू राइट दिस, आई विल पास।
अरे डोंट वरी,
Don't worry, the class will be in English only. The class will be in English only. It's already 8 p.m. and you know after 8 p.m. we all
चक दे फट्टे होने वाला
चक दे फट्टे, दब दे किल्ली, बना दे बिल्ली।
बिल्ली का ही तो
सर को मतलब बिल्ली बनाना अच्छा लगता है कि
घोड़ी,
घोड़ी बनाना अच्छा लगता है कि बिल्ली बनाना अच्छा लगता है आपको।
घोड़ी की सॉरी शादी नहीं होती, शादी में घोड़ी पे रहते हैं ना।
क्या बात है, आई विल पास थी तो झड़ी लगा दी है, ठीक है।
400 people are here. We'll start.
वेलकम वेलकम, लव यू ऑल यार। ये जोश है ना 12 तारीख तक कम नहीं होना चाहिए, फिर 12 तारीख तक कोई गलत काम नहीं करने हैं। देखो मैं बीमार था, मैंने भी नहीं करे 5-6 दिन, पर अब मैं ठीक है, चलो चलो चलो, बिल्कुल।
Yes, all question would be covered. Don't worry. Okay, so it's a very very important session. ठीक है, सबने अटेंड करना है, ठीक है, and will be available for later watching also. And all thanks to Nitin sir,
Yes.
giving his precious time
to us.
He was taking class, he left the class and came here just to take session for you. क्योंकि सर का मानना है कि सबका भला होगा तो ही तो ये देश तरक्की करेगा,
Yes.
है कि नहीं। चलो, so I think we'll give it to sir.
Yes sir, please start.
Thank you.
सर आप एक बार चेक कर लो पूरा सिस्टम,
हाँ श्योर सर, मेरे को बस वो चेक करना है सर अपना
आराम से
पीपीटी बस भी दे।
ये पीपीटी मैंने खोल दिया सर यहाँ।
अच्छा खुला हुआ ऑलरेडी सर,
ये
दिस वन ओके
पीपीटी आपका।
एंड इसका वो कर लेते हैं। अच्छा ये तो हमारा तो वो है ना सर, अब दे कॉल।
वाओ,
ठीक है सर, वाह वाह, ठीक है सर, ये आपका यहाँ पे भी है।
और वन नोट सर,
वन और नीचे आप समय खोल देते हैं।
हाँ उस पर लिखते रहेंगे,
हाँ,
बोलता रहूँ
सर,
सर।
मैं खोल देता हूँ
सर सर सर
खोल देता हूँ सर, ये या वन नोट ले लो, मैं आपका अलग से पेज खोल देता हूँ सर्जरी के नाम से, जो कुछ हाँ, ये आप सीसी में डाल दो सर, ठीक है
राइट सर,
सीसी में, ठीक है सर।
वी आर स्टार्टिंग इन अ व्हाइल।
बस तो ये सर अब आप ऑल टैप कर लेना, ठीक है।
राइट
ये
सर, राइट राइट राइट,
दोबारा ऑल टैप कर, ये एक हो गया आपका और वो आपका, ठीक है सर।
चलो राइट,
चलो सर, सी यू सर।
राइट 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 श्योर। नहीं नथिंग सर, नथिंग सो मच सर, इट्स लाइक दैट दैट इज अ स्क्रीन व्हिच इज ऑडिबल। ओके ओके, थोड़ा सा इसमें हल्का सा लैग है ना, बदल से इट्स ओके सर।
वो सर टाइम दिया हुआ इसके अंदर उसका,
ओके,
तो बाकी एडजस्ट हम कर लेंगे, कुछ होगा तो।
थोड़ा सा लैग लग रहा है सर,
हाँ
थोड़ा सा लैग लग रहा है ना इस पे आने में, डिस्प्ले आने में।
सर दैट विल बिकॉज क्योंकि रिले हो रहा है यूट्यूब से,
अच्छा ओके
दैट से थोड़ा लैग है,
ओके,
ठीक है सर।
बिकॉज हमारे पहले वाले में जरा सा भी लैग नहीं था, बस ओके। चलो राइट गाइस,
पोजीशन देख लेते हैं आपकी पानी वाली, अच्छा इधर तो मैं आपको थोड़ा सा, ठीक है सर।
ओके ओके ओके, हाँ वो स्क्रीन एरिया मेरा ज्यादा बच जाएगा,
ठीक है सर। चलो सर, बेस्ट लक।
राइट सर, राइट, थैंक यू सर, थैंक यू पारस। Right guys, kindly allow me to start. And first of all, don't worry, the class will be in English only. The class will be in English only. Only thing is we do the classes, or sometimes we crack jokes in Hindi because, you know, sometimes there might be some student who might be having some problem with understanding Hindi, with understanding English. Fine. So nevertheless, whenever we speak anything in Hindi and there are students who are not able to understand Hindi, we always repeat that. We always repeat that in English. So you don't have to worry. You don't have to worry. Fine. I believe now everything is working fine, I believe. Yeah. So don't worry. Thyroid, so thyroid. So we'll be doing it in extremely concise way. So thyroid, and definitely we'll be covering all the important points. Fine. So thyroid, from your knowledge of anatomy, that is the largest and it is also most superficial endocrine gland. Largest and most superficial endocrine gland. So when we talk about being the largest, it is around 20 grams size. 20 grams size. Fine. Priyam, you are here. So Priyam has been my favorite student all the time. So me and Priyam, we share some kind of non-veg chemistry. Fine. So we know that this gland regulates the basal metabolic rate. Basal metabolic rate of the body. Basal metabolic rate of the body. How? It secretes two hormone, T3 and T4 hormone. Sorry. So it will secrete two hormones, T3 and T4 hormone. T3 and T4 hormone. Fine. T3 and T4. Now, the gland will start working. Shibu, can you just switch the AC off? It's getting too cold for me. So gland will work upon the direction of TSH, thyroid stimulating hormone. Thyroid stimulating hormone. Fine. Now, so what we'll be studying here is about the relevant anatomy. About the relevant anatomy. Fine. Yes. So you see here. Now, because it is going to decide the basal metabolic rate. Anyone who is having hypothyroidism, that means low T3 and T4. Fine. What will happen? That patient will have very low basal metabolic rate. Whatever your patient is going to eat, every part of it will go towards storage. So your patient will become extremely fat like this. Fine. Extremely fat like this. This is the problem because of very low basal metabolic rate. Now for the beginners, more the T3, T4, more will be the BMR. More the T3 and more the T4, more will be the basal metabolic rate. Now, see, thyroid is an integrated topic. We study it in anatomy, physiology, biochemistry, everywhere we study. So let me just tell you briefly what kind of question they may be asked from the topic of, let's say, physiology. So they are going to ask that thyroid is making two hormones, T3 and T4. What is the percentage? So 93% will be T4, only 7% will be T3. And you know it from your knowledge of physiology that T4 is very less metabolically active. So main work is done by T3. Main work is done by T3. Yes, main work is done by T3, right? Now, so the thyroid gland has 90% of the body iodine. 90% of the body iodine. Fine. Now, so thyroid gland, it uses just 20% of the iodine. Whatever points I'm speaking today, they are all the questions which either have been asked in the past or they have chances to be asked in the coming examination. Fine. Now, it uses just 20% of the iodine and rest of the iodine is excreted in urine. Rest of the iodine is excreted in urine. Right? Now, coming to the relevant surgical anatomy. Relevant. Only the relevant surgical anatomy. So you see here, I did show you the image of the thyroid gland. So it is made up of right lobe, left lobe, and an isthmus, which is connecting both the lobes, right lobe, left lobe, and an isthmus, which is connecting both the lobes. So we say that it is a butterfly shaped gland, Fine. Now, the adult thyroid gland, I told you, is just 20 grams in size, but it receives around 100 ml per minute of blood. That means it is extremely vascular. Fine. It is extremely vascular. Now, we talk about the thyroid gland, and the question will usually come from the capsules of the thyroid gland, Let's say this is the thyroid gland. Now, you see it has got a false capsule. Fine. And then it has got a true capsule. Fine. So, two capsules, false capsule and the true capsule. Now, what is the question which is usually asked? That while you are performing surgery, which capsule you will always remove and why? So, the answer simply is that the true capsule is always removed. What is the reason? Fine. Now, let's say that you open an old can, and suddenly you see that there are many worms inside. Now, what are you going to do? You're going to close the lid and immediately throw the can out. Now, what happens is that below the thyroid true capsule, there are multiple hundreds and thousands of veins. Fine. So, let me just show you an image there. Yeah, you see here. So, this is the false capsule, this is the true capsule, and below the true capsule there are hundreds and thousands of veins. Now, while they are coming out, they all unite to form one single vein. Fine, they all unite to form one single vein. So, if you say that I am just going to remove the thyroid gland, I will leave the true capsule in the body itself, then you will have to deal with these veins, hundreds and thousands of veins, which is not an easy task at all. That is why it is said that true capsule should always be removed. While you're dealing with the thyroid gland. I'm sorry, I better stay here only, otherwise I'll block the view of the screen. Fine. Next thing which they ask is about the blood supply. Now, you see, thyroid gland has got two of the paired arteries, superior thyroid and inferior thyroid. Fine. And only unpaired artery is thyroidea-ema artery. So, what is special about the thyroidea-ema artery? It is the only unpaired artery of the thyroid. Fine. Now, the main blood supply is the inferior thyroid artery. Dr. Mango Shake, may I please know your real name? And you got to repeat your question. You need to kindly elaborate that what kind of question you are asking. I could not get your query properly. Right? Arterial supply of the thyroid gland. So, superior thyroid artery, that is the vessel which commonly bleeds. During thyroidectomy. Right? Now, about the veins, the venous drainage of the thyroid gland. So, the question which usually comes is, which vein is to be ligated first? So, it is the middle thyroid vein which is always ligated first of all. Why? because it is very small and thyroid is extremely vascular. So while you are performing the surgery, there are chances that you may damage the middle thyroid vein. There are chances that you may damage the middle thyroid vein. Fine. And because it is very, very small, you may not be able to locate it later. You may not be able to locate it later on. Fine. So it is always better to take control of this vein first of all. While you have given the incision, now the field is completely clean in front of you. You will be able to localize this vein very, very beautifully. Fine. But let's say you start dealing the other veins first. There are chances that there must be some bleeding. Then you won't be able to see this vein. So it is always better you see this vein first of all and you deal this vein first of all. Yeah, Dr. Shell Zero. Definitely I'll be slow. That has been a problem since the time I started teaching around 12 years ago. So from that time, that's my problem, that for first 5 or 10 minutes, I always speak very fast. What happens is after 5-10 minutes, some of the students, they point out and then I get slow. So that's a problem. That's a trend which is continuing for around 12 years now. I'm apologetic for that. I'll be slow. I'm really slow. I'm really sorry. Fine. Hello, buddy. So the question which usually will be asked is, what is special about the middle thyroid vein? Middle thyroid vein is the first structure to be ligated during surgery. Why? Because it is extremely small. Nobody, no, you don't have to say sorry. No, not at all. We are we because of you people. We are we because of you people. Fine. Without you, we don't have any kind of, we don't exist basically without you. Fine. So you don't have to say sorry. Right. So it is a middle thyroid vein which is ligated first of all. Now, what happens is that you sometimes encounter Cocker's vein. So Cocker vein, they drain the lower part of the gland. And you see, this is how you will get to see the Cocker vein. They will be draining into the internal jugular vein. Now, when we say that Cocker vein, so you need to identify some of the things which are starting with the word Cocker. Now you see, this is Cocker's forceps. Fine. Better term would be Cocker's hemostatic forceps. You see, there are 2 teeth. Fine. And then you can see there is a locking mechanism. This is how you identify Cocker's forceps. Fine. Next, this is Cocker's cervical incision, Cocker's cervical collar incision. So this is the name of the incision through which you do all kind of thyroid surgeries. Cocker's cervical collar incision. Now, what is this? This is Cocker's cervical incision. So by this, what you do is, you do modified radical lymph node dissection. You know from your knowledge of anatomy that 40%, at least 40%, minimum 40% of all the lymph nodes of the body, they are present in the neck region. Fine. So we might have to do their dissection at times. That surgery is called modified radical lymph node dissection. So the name of incision used is Cocker cervical incision. Fine. Now, there is another Cocker incision. This Cocker incision is called Cocker subcostal incision. Now, this incision we use when we have to do gallbladder surgeries. So one Cocker, so many terms. Fine. So you see, Sandeep, but I'm afraid that we don't do modified radical lymph node dissection in breast carcinoma. We do it in pharyngeal carcinoma. We do it in thyroid carcinomas. Fine. We don't do modified radical lymph node dissection in the cervical region in breast carcinoma. Fine. So what you are talking about, Sandeep Betaji, it is the axillary sampling. It is the axillary dissection which you are talking about in breast carcinoma. Yes, definitely. I will explain. But first, let's finish this topic of thyroid. After that, I'll do it. Don't worry. Now, I forgot to mention about another cocker. Fine. So cockers, fine, maneuver. What is cocker maneuver? Fine. So you see duodenum. Duodenum is retroperitoneal. Duodenum. Yes, definitely I'll send this PDF. Duodenum is retroperitoneal. Fine. So when you want to bring duodenum to the front, fine, in that case, that surgery is called as cocker maneuver, or that is called as cockerization of the duodenum. Now, you see, this is the mnemonic of retroperitoneal organ. So if you are studying the anatomy, if you are studying the GIT, you should always be aware about this mnemonic. Sad pucker. I'm not going to elaborate because we are studying thyroid. We are not studying retroperitoneum here. Fine. But this mnemonic, this is your homework kind of thing. Fine. Sad pucker. This is the mnemonic of retroperitoneal organs. Moving forward. Now, this is important thing that while you are performing thyroid surgery, you see, surgeon is only concerned about one thing, that is recurrent laryngeal nerve injury. So please allow me 1 or 2 minutes. Those of you who are here that will be doing it super duper fast, please maintain some patience and kindly allow me 1 or 2 minutes, because this is an extremely important topic. So you see, we have vagus nerve, the 10th cranial nerve, coming out of the skull through the jugular foramen, right? Now, you see, it has two branches. One is the superior laryngeal nerve. Second is the recurrent laryngeal nerve. When we talk about the branches, superior laryngeal nerve has further two branches. Internal laryngeal. This is a sensory nerve. External laryngeal. This is a motor nerve. Only one muscle, cricothyroid. Recurrent laryngeal nerve, two branches. Lateral, which is sensory, fine, and medial, which is motor. Right? Now, so if we have to identify, fine. So the question usually comes that where is it identified? See, the most common site of injury of the recurrent laryngeal nerve, what is that? This is Bailey's ligament. Another question which is commonly asked, where it is most commonly identified. So it is most commonly identified at the level of cricoid cartilage. What are the different triangles to identify? Simon triangle, Behr triangle, and you see Behr triangle is also called as Riddle triangle. Beher triangle is also called as Riddle triangle. So let me quickly show you all the triangles. Let me quickly show you all the triangles. Then I'll tell you about something more about the recurrent laryngeal nerve. So you see here, this is the Simon triangle and these are the boundaries. These are the boundaries. Carotid artery forms the lateral boundary. Trachea forms the medial boundary. Fine. While the inferior thyroid artery will form the superior boundary. I don't think it's wise to call it as inferior laryngeal nerve. No, it's not wise because that is a typical course of recurrence. Now, Beher's triangle, you see here, recurrent laryngeal nerve itself will form the superior, will itself be a part of the boundaries, there. You see here, the inferior thyroid artery, that will form the superior boundary here, see. Now, you see, this is the Beher's triangle. So, superior boundary will be formed by inferior thyroid artery. Fine. Lateral boundary will be formed by common carotid. Fine. And inferior boundary will be formed by recurrent laryngeal nerve itself. Fine. Now, Riddle triangle, that's practically the same. You can see by yourself that is practically the same. Riddle triangle. Jaw triangle is for identifying the superior laryngeal nerve. Jaw triangle. You don't need to remember the boundaries there. Just remember the name. Fine. Jaw triangle. Now you can see there is another triangle there. That is called as the triangle of concern. Now triangle of concern is about vascular accident. So this is the area where maximum vascular accidents have occurred in the past. This is the area where there is maximum chance, where there are maximum chances of bleeding. Triangle of concern. Beta, mango shake, beta, your name is Rahul, I forgot. Rahul, only the names can be asked. Only the names, not the boundaries. They're not going to ask you the boundaries. Only they can ask you is the name. Only thing they can ask you is the name. Fine. Now, so I want to tell you more about the recurrent laryngeal nerve. So you see, recurrent laryngeal nerve. So it is shorter on the right side. Fine, it is shorter on the right side. It runs more oblique on the right side. Third, on the right side, there are more chances of the nerve being, non-recurrent. Fine. So recurrent laryngeal nerve injury will be much more common on the right side. Fine. Now, there is another doubt there. That about the nerve injuries. See, most commonly injured nerve is superior laryngeal nerve. Fine. Now, most commonly injured branch of recurrent laryngeal nerve, it is the medial branch. Which is most commonly injured. Right? So, We'll return to the recurrent laryngeal nerve once again, but then first start the lymphatic drainage. Lymphatic drainage. See, thyroid lies in the anterior triangle of the neck. Thyroid lies in the anterior triangle of the neck. So let's say here lies the thyroid gland. So most of the drainage will go to level 6 lymph node, level 6 lymph nodes. Fine. That is, see, this is the level 6. You can see level 6 lymph node, that is the central compartment lymph node, central compartment lymph nodes. So that will include pre and para. That means in front and on the side. Pre and paratracheal lymph node. Fine. That will include Delphian lymph node. We can also call them pre-laryngeal lymph nodes. Fine. You see here, Delphian lymph nodes. Pre and paratracheal lymph nodes. Pre and paratracheal lymph node. All of them, they are present in the center. They are present in the center. So we call them level 6 lymph node. We call them level 6 lymph node. Fine. We call them level 6 lymph nodes. Now, ultimately, from the level 6, the drainage can go to 2, 3, 4, 5, and even up to level 7 lymph nodes also, even up to level 7 lymph nodes. Mohib Khan, I like your dance move, but what kind of dance move is this? So when you pass the exam, we'll have a dance session over here, and you have to be here, please, by request. So when we do thyroid surgery, along with that, we do central lymph node dissection. We do central lymph node dissection. Can you just give me a quick minute, please? Just give me a quick minute. I'm sorry. I forgot to switch my phone off, so that's what I did right now. Very sorry about that. Okay. So when we do the thyroid surgery, we do the central lymph node dissection. That means we remove level 6 lymph node. When we do it for aggressive cancer, we remove level 2, 3, level 4, and level 5, also level 7 lymph nodes also. So when we do both of them together, that will be comprehensive neck dissection. When we just remove these lymph nodes, that will be modified radical lymph node dissection. Modified radical lymph node dissection. Thank you, buddy. Thank you. Fine. So with this, we were about to end the topic of anatomy, but then there might be some image based question. Fine. So what is this? This is Pizzillo's method. That might be asked as an image based question. You see here, while the patient does like this, keeping the hands behind the head, that will make the thyroid gland much more prominent. So with Pizzillo method, what we are doing is inspection of the thyroid gland. Inspection of the thyroid gland. Leahy's method, what we do here is we do the palpation of the thyroid gland. Palpation of the thyroid gland. Kreil's method. So Kreil's method we do, you see here. Let me write on this side the swelling which arise from skin and the swellings which arise from thyroid. We all have read that swelling of the skin they will be static, while the swelling from the thyroid, they move up on deglutition. So with the Cryle's method, we are checking whether the swelling which is present in the neck, is arising from the skin or from the thyroid gland. So any swelling which is arising from the skin, that will remain where it is. We ask the patient to swallow something. So if the swelling is arising from the skin, it will remain where it is. But if the swelling is arising from the thyroid gland, it will move up. So that is Cryle's method. Cocker's test. So you know what we check. With Cocker test, we check if the patient has tracheomalacia or not. Tracheomalacia. Fine. So you see here, this is what is tracheomalacia. Fine. Eye signs in hyperthyroidism, grave disease. They can be asked as an image-based question. See there. Now, different signs. Von Graffe sign. Remember what is von Graffe sign? Let me choose a better color there. Von Graffe sign. Remember, it was lid lag sign. Fine. Mobius sign is lateral blinking, absence of normal blinking. Dr. Rahul, tracheomalacia is when the trachea becomes extremely soft. You can very easily compress the trachea. That is tracheomalacia. Darlymphal sign, you see, normally we are not able to see this part of the sclera and cornea. But here in the thyroid gland, because the eyeballs, they are pushed forwards. So you are able to see the upper part of the sclera as well. You can see here in this image only, you can see the upper part. You see this upper part, you can clearly see. Normally, you watch yourself in the mirror, you won't be able to see the upper part, right? That is Darlymphal sign. Gifford sign, you are not able to invert the upper eyelid because it is edematous. Cocker sign, fixed gaze, patient will be looking in one direction only because he knows that if he has to move the eyes, that will involve lots and lots of efforts, right? So, Jelinek sign is hyperpigmentation of the upper eyelid. Enroth sign is edema of the lower eyelid. Nafziger sign, we can call it proptosis or exophthalmos, whatever you want to call it. Sat Sri Akal, Inderjeet Singh Khalsa ji, in the lid lag, the cornea of the eye becomes conus. Bhai, itni ophthalmology nahi aati. To be honest, I mean, I'll be very honest, I don't remember. Sure, beta, sure. So this is all physiology. Now, you see here. Now, please let me briefly explain about the thyroid scan. I thought that I had switched my phone off. So, thyroid colloid scan. Fine. Now, you see here. What we do is, we know that whatever iodine we give to the patient. Sandeep, you sure you want me to repeat? Okay, just give me a minute. I'll do it very quickly. Because others may not be in a mood to get the repeat kind of thing. So, Stalwag sign. The patient will not be blinking normally because his eyes are inflamed. Geoffroy sign, because everything is inflamed, so there will be absent of normal wrinkling. You see, when I look up, you see the wrinkles on my forehead, so there will be no wrinkling on the forehead of this patient. Mobius sign, when you ask the patient to converge like this, I can do it, but this patient will not be able to do it because everything is inflamed. Over here. Lid lag sign, you make the patient go up and down. Finger goes up and down and you ask the patient to follow. Patient will not be able to follow it. Fine, because his eyes are inflamed. Dark lymphal sign, because eyeballs are pushed forward. So the upper part of the sclera will be visible. Fine. Gifford sign, because upper eyelids are inflamed. So you cannot avert them. You cannot avert them. Right. Cocker sign, fixed gaze. Patient will be looking in one direction only. Patient will be looking in one direction only. Fine. Jelinek sign, because of continuous edema, there will be hyperpigmentation of the upper eyelid. Anaroth sign, there will be edema of the lower eyelid. Nafziger sign, proptosis or exophthalmos, whatever you want to call it. Fine. Both are correct. Now, please allow me to explain the thyroid colloid scan. So we know whatever iodine we give, 90% of iodine will be taken up by the thyroid gland. Fine. So what we do is we give our patient radioactive iodine. Fine. Now, you see here. Let me just show you. This is the normal scan. So wherever you can see gray or black, this is the normal distribution of iodine, radioactive iodine. Grave disease, entire gland is hyperfunctional. So there will be too much concentration of the iodine. What do we do? What do we call it? We call it worm scan. We call it worm scan. Now, toxic adenoma, it is also known as Plummer disease. One of my students mentioned that, sir, is it similar to Plummer-Vinson syndrome? No, Plummer-Vinson syndrome is totally different. Plummer-Vinson syndrome will affect the upper part of the esophagus. This is Plummer disease. This is Plummer disease. Toxic adenoma. One part of the thyroid gland becomes hyperactive. One part of the thyroid gland becomes hyperactive. Fine. So this is called as hot nodule, Dr. Rahul. This is called as hot nodule. You see, in this region, which I have shaded red right now, there is too much of iodine, here. Fine. This is hot nodule. This is called as hot nodule. You see, in this area, there is no iodine. This is called as cold nodule. What may cause the appearance of cold nodule? Thyroid cyst, thyroid cancer. Fine. So these are the common diagnoses. These are the common diagnoses of cold nodule. Cold nodule. Yes, Dr. Modi. Plummer-Vinson is associated with iron deficiency anemia. Commonly, it is associated with iron deficiency anemia. Now we come to the congenital disorder, that is ectopic thyroid. And you see this, we are seeing lingual thyroid. Lingual thyroid. Now, what the question they commonly ask is, what is the most common clinical feature of lingual thyroid? The most common clinical feature here, you see, because it is very, very small. So let me just write it over there. So, lingual thyroid, most common clinical feature is hypothyroidism. You see, because it is very, very small. Fine. Naturally, it can cause dysphagia also, but the most common clinical feature is hypothyroidism only. Now, the next question comes, and we all make mistakes. We all must have made this mistake, that how to diagnose this condition. So, the best modality to diagnose this condition is clinical examination. Don't write any test. The best modality to diagnose is clinical examination. Fine. What is the clinical examination there? So it will present as posterior pharyngeal mass. It will present as posterior pharyngeal mass. mass. Fine. So if at all you have to do any kind of examination there, fine, then you can do radio iodine scan. Fine. What is the treatment? Best treatment is excision. Why? Because there are chances of follicular carcinoma. Right? So coming to the next is thyroglossal cyst. Fine. You see here, thyroglossal cyst. Now, so this is the midline. You'll notice one thing, that it is more towards the left and less towards the right. More towards the left and less towards the right. This is the first question which they usually ask. So thyroglossal cyst. So this occurs from degeneration. My humble request, please make good use of this. If you have got any query, see, we are here for we are together for 1.5 hours probably. So my humble request is for you guys to make good use of this time, and if you have got any query, please do send that query to me over here only. Fine. So thyroglossal cyst occurs from degeneration of thyroglossal tract. Mayank, you must send that again, buddy. I have no ego issues. Fine. So this is more commonly seen in the subhyoid location. Fine. So midline, but slightly towards the left. Fine. Midline, but slightly towards the left. Treatment is cyst trunk operation. That means you have to remove the cyst. You have to remove entire thyroglossal tract. Fine. And you have to remove even the middle part of the hyoid bone. Now, if you don't remove it, it can land up into becoming a thyroglossal fistula, because this is the concise class. Fine. So you must be aware about the most important things. First of all, this is never congenital. Fine. So it will occur either from infection of the thyroglossal cyst, fine, or from the inadequate removal. What are the characteristic sign? Hood sign and semi-lunar sign. Fine. You see here. See, this is the hood sign and semi-lunar sign. So this is called pathognomic. Of the thyroglossal fistula. Second thing, that it is always in midline. So which fistula is away from the midline? It is the brachial fistula. You see, this is the midline and this fistula is away from the midline. So your patient will have a brachial cyst and a brachial fistula. So brachial cyst and fistula, they are congenital and they are away from the midline, midline, while the thyroglossal fistula is never congenital and it is always present in the midline, always present in the midline, right? Now, this is an extremely important topic there. What? The solitary thyroid nodule. That means the single thyroid nodule. The question which usually are asked is, what is the first investigation? What is the first investigation? So the first investigation in any single thyroid lesion is thyroid function test. Always thyroid function test. And most of the time they don't ask about the investigation of choice. But if they ask you what is the investigation of choice for solitary thyroid lesion, the answer would be FNAC, fine needle aspiration cytology, fine needle aspiration cytology, right? Now, what is the role of ultrasound in solitary thyroid nodule? So, ultrasound we use to differentiate solid from the cystic swellings. Solid from the cystic swellings. Dr. Yash, we cannot call it non-congenital. See, what you are talking about is thyroid cyst. Thyroid cyst can be non-congenital and it in fact is non-congenital. But thyroglossal cyst will be congenital. Only thing is that it can present between adulthood, between 10 to 30 years of age. Fine. So that may sound like non-congenital, but actually it is congenital. To differentiate solid from cystic swellings, right? Now, another common question which is usually asked is that what are the limitations of FNAC, fine needle aspiration cytology, where it is not useful? So, the first, it cannot differentiate between follicular adenoma and follicular carcinoma. The second thing, it cannot differentiate between Hürthle cell adenoma and carcinoma. Fine. Third thing, we cannot use it in riddle thyroiditis. See what happens in riddle thyroiditis, that the gland becomes extremely hard and fibrous. So once you insert the needle, it will break down. So this will not be of any use. Fourth, if there is multicentric disease, simple way to remember is that you might insert one needle and you might miss another focus of infection. Fine. So these are the 4 areas where FNAC may not be useful. FNAC is fine needle aspiration cytology. So I believe Dr. Muthalia Mauni Raghuram has already given the answer, but let me just tell you, because this doubt is commonly asked there. Now you see here. So in follicular adenoma, let's say this is follicular adenoma. Let's say this is follicular carcinoma. This is follicular carcinoma. And this is the capsule of the thyroid. This is the capsule of the thyroid. Fine. Now, what is the problem in the follicular neoplasm? That cells, they are arranged in the form of follicles. Fine. Now, this is benign. You can see that it is not involving the capsule. This is malignant. This is involving the capsule. This thing we cannot see on fine needle aspiration cytology. So FNAC is fine needle aspiration cytology. Yes, Dr. Saif Shah has also given the right answer there. Right? So this is what they commonly ask. This is what they commonly ask. Yes. Now this thing, retrosternal goiter, retrosternal goiter. What are the common things which they ask here? What are the common things which they ask here? But I believe before we study the retrosternal goiter, let's see the other things like grave disease. Now you see here, what is a problem in the grave disease? That this is an autoimmune disease where autoantibodies develop against the TSH receptor. Now these receptor antibodies, what kind of antibodies are they? Let me just see if I can use an eraser there. No. I'll have to choose an eraser from here. Yeah. So what kind of antibody are they? They are stimulatory antibodies. They are, yes, they are stimulatory antibodies. Dr. Yash will come to that, don't worry. Fine. So consequently, what happens is size of the gland increases. Fine. And your patient becomes hyperthyroid. What do we mean by the term hyperthyroid? You see, there is a difference. Hyperthyroid just means increase in the level of T3, T4 hormones. And because your patient becomes hyperthyroid, your patient becomes thyrotoxic. What is thyrotoxic? That means the clinical features due to increased level of T3 and T4 hormones. So you see there is a big difference there. There's a big difference there. Fine. Now, both your patient will become hyperthyroid, your patient will become thyrotoxic. So next is, they say, what is the investigation? You do the radioactive iodine scan. Fine. And it will show warm scan. It will show warm scan. Now, what is the primary treatment? Your patient needs quick resolution of the symptoms. Fine. So you will advise your patient drugs, the anti-thyroid drugs, Now, which drug is to be preferred? Methimazole, once a day dose. You see, when you use propyl thiouracil, it has to be given at least 4 times a day. 5 times will be an exaggeration. So let's better write it as 3 to 4 times a day. I'm really sorry about that. 3 to 4 times a day. Fine. So compliance may not be achievable. You might not be able to convince your patient to have 4-5 tablets every day. Fine. But with methimazole, this is better. Fine. Propranolol we can use if your patient is having like these clinical features like this, extrapyramidal features they are called. Fine. Now, for the patient who are less than 45 years of age, the preferred treatment is surgery. For the patient more than 45 years of age, the preferred treatment is radioiodine ablation. And this time we will be using different iodine, iodine 131. Fine. What's that, Papa aa gaya? In pregnancy, we'll be using propyl thiouracil. That is the benefit there, propyl thiouracil. So we'll be using iodine 131 over here, iodine 131 over here. Right? Now, must remember one thing, that whenever your patient develops multinodular goiter, the only treatment option which you have is surgery. Now, it is said that because of the risk of development of cancer in young patient, you do total thyroidectomy. In elderly, you do subtotal thyroidectomy. Subtotal thyroidectomy. Dr. Rocket will be using 131. 123 is for using yeah. I really like your name, buddy. Can you tell me your real name? Now, next comes your iodine deficiency goiter. Fine. Iodine deficiency can be primary, that is dietary. Your patient may be having food fads. He says, I won't be eating the iodinated salt. Fine. He says, I won't be eating the iodinated salt. I will eat rock salt. I will eat kosher salt. So he might develop deficiency of iodine. Fine. And then it could be secondary. Your patient is having goitrogens in the diet. The brassica group of vegetable, cabbage, cauliflower, kale, kelp. Fine. All these things. But I like it. That adds cheers to the class, the different names and all. Now, whatever be the reason, you must be aware about two things there. Let's say your patient is having primary iodine deficiency and he develops a large goiter. And on the top of it, you give your patient large amount of iodine. You give your patient large amount of iodine. So suddenly your patient will develop hyperthyroidism. Your patient will develop hyperthyroidism. You see here, what is this effect called? This effect is called Jod-Basedow effect. One-liner, popular one-liner there. So what is Jod-Basedow effect? It is iodine-induced hyperthyroidism. Now, so there is a transient effect called Wolff-Chaikoff effect. Wolff-Chaikoff effect. What is Wolff-Chaikoff effect? That is iodine-induced hypothyroidism. As if the iodine which you gave practically switched the thyroid gland off. Practically, it switched the thyroid gland off. Fine. So that is called as Wolff-Chaikoff effect. Fine. So this effect is transient, 100% transient. Fine. Wolff-Chaikoff effect and Jod-Basedow effect. Now this important term, retrosternal goiter, extremely important. What? When 50% of the thyroid gland is in the chest. Now, it could be primary, that means the goiter is arising from ectopic thyroid gland in the chest. It must be kept in mind that it is extremely rare. It could be secondary, that means it is extension of the neck goiter. It is extension of the neck goiter. Now, the common questions which they ask, is, fine, what kind of questions are expected? That what are the clinical features? So because the trachea will be compressed, there will be dyspnea. And you see, this dyspnea will be much more marked at the night time. Why? Because at night time your patient is horizontal. So the thyroid gland will practically compress the trachea, Let's spend a minute over here. Let's say this is the thyroid gland. During daytime, your patient is vertical. So trachea will not be compressed. Fine. This is the skin. This is the thyroid gland, and let's say this is the trachea. Fine. At night time, what will happen? Your patient will become horizontal. Your patient will become horizontal. So practically what will happen? The trachea will be badly compressed because the gravity will be pulling the thyroid gland in the other direction. So that is why it is said that dyspnea is more marked at night time. What else you should be aware of? Pemberton sign. Someone just mentioned that it will press the superior vena cava. All the neck veins which were going to drain in the superior vena cava, they will be compressed. When the patient raises his or her arms above the level of shoulders like this. So you see here the color is brown, but here the color has become pink. That is called as Pemberton sign. Pemberton sign. Fine. Pemberton sign. Yes, exactly. Muthalia Mauni. I'm really sorry if I cannot pronounce your name correctly. I'm really sorry. Raghuram. Fine. Now the next thing which you get to see is scabbard trachea. Scabbard trachea. What is scabbard? Scabbard is a curved knife. So you see, you got to see a curved knife over here. Curved knife. Scabbard trachea. Fine. Scabbard trachea. Let's just give me a second, please. Right? Scabbard trachea. So you can see the trachea is bent in one direction. Trachea is bent in one direction. So this is more like a curved knife. More is like a curved knife. Neeraj Kumar ji, you're always welcome. You're always welcome. In fact, all of you are always welcome at my place. You clear the exam and be there. We'll always have a party over there. We can always have a party over there. Fine, you're all welcome. You're all welcome. Now you see the thyroid gland. The thyroid gland here you can see. Fine, in the chest. That is a retrosternal gland. Retrosternal gland. Now, so before we move to the topic of cancer, let me tell you that we must never use iodine 131 in the retrosternal goiter. Why is this so? Why is this so? You see here, in the neck, the important structures, they are present very far away. Let's talk about the carotid arteries. They're present very far away. Fine. So even if you give your patient radioactive iodine, fine. So the important structure, they are present very far away. But if you give this while the patient is having retrosternal goiter, your patient can sustain severe damage. Why? Because the structures are present nearby. Structure are present nearby. So that means we are not going to use iodine 131. We are not going to use iodine 131 in the management. Right? Now, what is the treatment? Then surgery. Now, 50% of the thyroid gland is present in the chest. 50% of the thyroid gland is present in the neck. Fine. So what is to be opened? Whether you are going to open the chest or you are going to open the neck. So naturally you will open the neck. Neck. In 99% you can do the surgery by cervical incision. Fine. Now thoracotomy, that means the chest incision you will use only and only if there are, you expect that there is risk of cancer. Fine. So second thing, that you see that the goiter is arising from ectopic thyroid gland. The third thing, there is history of previous neck surgery. Fine. Yes. Rarely, very rarely. Thoracotomy, sternotomy is one and the same thing here. Fine. So we'll do it in less than 1% of the cases. That is a question which has been commonly asked. Maybe you're following the 10 years already and you know that this question has been commonly asked, there, right? Okay. So we move to the next thing there. Now we have to study about the thyroid cancers. Because of the limitations of time, we cannot discuss the thyroid cancer in great details, but let's say on a conservative estimate, around 80-90% of the question will come from this table only. Fine. So let's see, we have a table about the thyroid cancers there. Fine. We'll write on this side the different thyroid cancers: papillary cancer, follicular cancer, Hurthal cell, fine, cancer, and anaplastic cancer, right? So we'll just draw this one table and you'll see that we'll be able to cover 80-90% of your questions. Open your MCQ books and you'll see you'll be able to solve. Okay, let me claim 100%. You will be able to solve all your cancer questions here. Please see. Fine. So we'll see what is the incidence. 70 to 80%. That means it is the most common. Remember this thing only. This is sufficient. Fine. Follicular carcinoma and Hurthal cell carcinoma, both taken together, make around 10% of the total thyroid cancer. Medullary thyroid carcinoma, less than 5%. Anaplastic, 1 to 3%. Voice is breaking. Let me see. Just read this table and you will be able to solve all the questions from the thyroid carcinoma topic, I believe. And you please do try this. Incidence. Then we talk about the age. So this is 30 to 40. Follicular and Hurthal cell, around 50 years. Medullary thyroid carcinoma, 55 to 65. Now, because I want to make it 100, so familial cases may present in younger patients also. Thank you, buddy Walter. Thank you. I'm so glad by your kind and humble words. So this will be common in 70 to 80 years. This will be common in 70 to 80 years. Yes. Now, when we talk about the biological behavior, that is a loose term just to make you understand. I think there is some lag, but I don't think, I can't find the lag on my screen as of now. No. Maybe you should try closing all other tabs. And then this thing will become extremely clear. Biological behavior. You see, this cancer is least malignant. Follicular cancer is aggressive. Hurthal cell is very aggressive. Medullary carcinoma is also very aggressive. Anaplastic carcinoma is extremely aggressive. You'll just come to know why. Dr. Victory, maybe I can see on my screen. I don't find, I mean, there is lag, but of one or 2 seconds only, maybe not too much lag. Now, because it is a cancer, so naturally it will spread. Fine. So most common route of spread, lymph node, up to 40% of the patient will have metastasis, metastatic lymph node at the time of presentation. Fine. Follicular, blood, Hurthal cell, blood plus lymph nodes, medullary, blood plus lymph nodes, anaplastic carcinoma, any other, it will go and grab the organ directly. It will go and grab the organ directly. Most common organ involved in case the spread is by blood. So it is going to be the lungs. Follicular, it is going to be the bone. Same for Hurthal. Medullary carcinoma, it is going to be the liver. Anaplastic carcinoma, again it is going to be the lungs. Fine. Surgical treatment for papillary thyroid carcinoma, earlier, not now, we were doing near total thyroidectomy, but these days we are doing total thyroidectomy because the cancer is going to involve lymph node, so it will involve central lymph node. That is level 6 lymph nodes will be involved. So we will do central lymph node dissection. If other lymph nodes are involved, we will do modified radical lymph node dissection. Is the voice breaking for everyone there? I can just hold the mic in my hand like this. But I can listen to the voice clearly on my laptop there. Dr. Yash, Dr. Sharmada Kanan. Is my voice clear? What? Yes, no, continuing. Okay, let me see. I'll hold the mic like this. Fine, I'll hold the mic like this. Now, when we discuss about the bones, when we discuss about the follicular carcinoma, see, for the follicular carcinoma is an aggressive carcinoma. So, we'll be doing total thyroidectomy. You see, because the cancer will not go through the bone, so lymph node dissection is often considered unnecessary. Fine. But when we talk about the Hurthal cell carcinoma, treatment will be total thyroidectomy plus central lymph node dissection plus modified radical lymph node dissection. Same thing for medullary thyroid carcinoma, will be doing total thyroidectomy plus central lymph node dissection plus modified radical lymph node dissection. And this is the cancer where we offer prophylactic thyroidectomy to the relatives. You sure? Aliza, जी अपने बच्चों की बात कैसे मोड़े? अब बच्चों ने कहा है कि मत पकड़ो माइक को, तो छोड़ना पड़ेगा. Fine. For anaplastic carcinoma, treatment is the same. Total thyroidectomy plus central lymph node dissection plus modified radical lymph node dissection. Fine. This table, I believe, covers most of the questions. I'll just zoom it up a bit. This table covers most of the questions of the thyroid. Right? Most of the questions from the thyroid cancers. Fine. Now, you see here, that what else they can ask you? What else they can ask you? They can all ask you about the gene mutations. They can ask you about the gene mutations which are associated with the thyroid cancer. For example, BRAF gene mutation can be associated with papillary thyroid carcinoma. Fine. PTC1, PTC3 gene mutation can be associated with papillary thyroid carcinoma. 10 gene mutation can be associated with follicular carcinoma, but the most important is RET gene mutation. Most important is RET gene mutation, which can be, yes, definitely we'll share. RET gene mutation can be associated with medullary thyroid carcinoma, and this is the screening which we do when we are doing when we are checking on our patients. So we advise the relatives of the patient to undergo gene screening, and if they are found to carry RET gene mutation, we advise them to undergo prophylactic thyroidectomy. Fine. Now, medullary thyroid carcinoma can be associated with MEN 2A or MEN 2B group of tumors, multiple endocrine neoplasia. Atul, let me repeat, bete. If your patient is having medullary thyroid carcinoma, there are chances that his family members too may be suffering from, may suffer from medullary thyroid carcinoma in the times to come. So what do we advise them? We advise their family member, get yourself screened for the RET gene mutation. If you have RET gene mutation, there are chances you might develop thyroid cancer. So it is better to get your thyroid removed. Yes. Remember in this the lobular carcinoma in situ, we advise the patient to undergo prophylactic mastectomy because there are chances of development of cancer. Similarly, if your patient is having RET gene mutation, he may develop cancer sooner or later. So it is better that you advise your patient to undergo prophylactic thyroidectomy. Right? Now, we see the cancer surgeries. So your patient will be kept in the rose position. That means the neck will be hyperextended. Shoulder, below the shoulders will place a pillow. Fine. And incision, I told you, cervical, the different surgeries. You do hemithyroidectomy involving a single lobe. You cut the affected lobe, you cut the isthmus. Fine. And this surgery, heart laid downhill, do in the past, heart laid downhill. So that means you cut affected lobe. Please allow me to call this AL. Fine. Then you cut the half of the contralateral lobe also. Half of the contralateral lobe. Shekhu bete, it is the papillary thyroid carcinoma. It has excellent prognosis. Voice breaking. Nevertheless, we are about to finish. Don't worry. But what about you have to read like this? Just give me a second. I'll ask Dr. Shibu to check. Please wait for a while. Sir. Just a minute. Please, buddy. I'll ask them to check. You want to do something about it because the voice is lagging.
It's fine, sir.
So say it's lagging. Maybe they are tired, no? Now it's fine, sir. Okay. Now it's fine.
Hello. Okay.
So are you guys tired or something? Okay. So let me just repeat. Don't worry. So let's say the surgeries. If they ask you, why do we do hemithyroidectomy? So hemithyroidectomy is done if there is a benign disease affecting just one lobe of the thyroid. Benign disease affecting just one lobe of the thyroid. What do we cut over here? Cut the affected lobe plus we cut the isthmus. Hemithyroidectomy. Now we have another surgery, that play Dunhill operation. Now this surgery is of historical only. We are not doing anything like this. So what do we cut here? We cut the affected lobe plus we cut the isthmus, and we also cut half of the contralateral lobe. We'll cut half of the other lobe also. So please let me draw this. Let's say this is the isthmus, right lobe, left lobe. Fine. So this is what we cut if we have to perform hemithyroidectomy. If we extend it further to include this, let's say there's a problem here. So this much if we cut, that is hemithyroidectomy. This much if we cut, that is Hartley Dunhill operation. What is the purpose of Hartley Dunhill operation? That brings us to another one-liner. What? That most of solitary thyroid nodules, they arise from junction of one of the lobes with isthmus. No, Dr. Yash, we are coming to that. We are coming to the subtotal thyroidectomy. Earlier we used to do this in place of subtotal thyroidectomy. Now we are doing subtotal thyroidectomy. That is why I told you it is of historical interest only. Fine. Now, so semoma bodies. So you have to answer in which thyroid cancer we see the semoma bodies. P, semoma. So it will be seen in papillary carcinoma of thyroid. But this is not a specific finding. See, capillary carcinoma. Can anyone please tell me what is the name of this gene? PAX8. So PAX8 gene is called as paired box gene. It is called as paired box gene. Yeah, it's stuck. No, we are back. We are back. We are back. So we're back with you. It's not disconnected. No. I think so. Okay. So Paxate gene is called as paired box gene. Okay, bro. Anything for you, anything for you. So Semoma bodies can be seen in other diseases, also. Fine. So they are concentric calcified structures. Fine. Now, orphan any nucleus, that is a more specific finding. So if you see orphan any nucleus in any of the specimen, that will be much more specific finding. Now these are the gene association with follicular carcinoma, P10, and Paxate gene. The other name of Paxate gene is paired box gene. I believe there's too much lag. Please comment on the lag. Is there any lag, voice or video? I can notice the lag on my screen. This practically never happens, but I don't know why this is happening like that. So you see, this is the rose position. You can see the neck is hyperextended. Okay. Now, this is the surgery, subtotal thyroidectomy. So we do it only for multinodular goiter, especially if the patient is elderly. Fine. Now what we do is, we'll leave 3 gram of tissue here, 3 gram of tissue on the other side, 3 gram of tissue on the right side, 3 gram of tissue on the left side. Why are we doing like this? We are doing like this because we are so concerned about the recurrent laryngeal nerve. So if we go on dissecting in this area also, we might damage the recurrent laryngeal nerve. We might damage the parathyroid glands there. Fine, we might damage the parathyroid glands there. That's not what we expect over here. Fine. So we don't venture into this area, subtotal thyroidectomy. How are we going to calculate? See, our fingertip is around 3 grams. 3 grams here, 3 grams there. Now, near total thyroidectomy, we only used to do it for papillary thyroid carcinoma, but this is now replaced by total thyroidectomy. So what did we used to do over here? 1 gram on right side, 1 gram on left side. Fine, because this was done for cancer. We used to remove large amount of tissue. Fine. Total thyroidectomy, naturally this is the standard surgery for all the cancers. This is considered the standard surgery for Graves' disease. Fine. Now, minimally invasive video assisted thyroid surgery. Your patient does not want a scar, even though the horizontal incision is going to give a very good scar, but patient says, I don't want any scar at all. Fine. Now, the essence of it, that you can only remove small goiters. The essence of it, you cannot perform this surgery safely if there are adhesions. Fine. So you see here, Contraindications are more important. If there is thyroiditis, there will be fibrosis. If there is neck radiation, there will be fibrosis. Previous neck surgery, fibrosis, obesity, very short neck is expected. Very short neck is expected. So if at all, the question is based on this, MIVAT, minimally invasive video assisted thyroid surgery, they are going to ask you about the contraindications. So you see, it is done if it is very easy to remove the thyroid gland. Difficult thyroid gland we can still not remove by video assisted. For that we'll have to do open surgery only, right? Now, they're commonly going to ask you the complications. Fine. So the first is respiratory obstruction. The most common cause will be laryngeal edema. It could also be a hematoma. Fine. And then what you're supposed to do is you have to remove all the sutures. Only treatment is remove sutures. Fine. Your patient will be fine in no time. Second complication is hypoparathyroidism. Hypoparathyroidism. So it will present as hypocalcemia. And what question they are going to ask? The first clinical feature. The first clinical feature will be perioral tingling. Yes, we do give. First clinical feature will be perioral tingling. Your patient will say, I'm having tingling sensation around my lips. Fine. Now, next, your patient might have Vostek sign. Let me just write it clearly. Your patient might have Vostek sign. So that means when you tap on the facial nerve, there will be twitching of the facial muscles, Vostek sign. After that, even though it is uncomfortable, your patient might display Trocheus sign. Trocheus sign is like carpopedal spasm. Fine, carpopedal spasm. Fine. That is also called as obstetrician's hand. Fine. Now, the mother of all the complications is recurrent laryngeal nerve injury. Now, if this is unilateral, your patient might present with hoarseness of voice. Most of the times it could be ataxia. In that case, it will recover within 6 weeks. What is the treatment if it does not recover? What is the treatment? That mediation of the cords. So this is basically done for good voice. If the injury is bilateral, fine. In that case, your patient might not be able to breathe. He might not be able to recover out of anesthesia. Fine. So, if the injury is bilateral, your patient will have dyspnea. He won't be able to breathe. Fine. Now, what is the treatment? Immediate re-intubation. Patient again. Immediate re-intubation, and then lateralization of the cord so that your patient can breathe normally. Yes, it is life-threatening. Let me check. We're left with just 2-3 minutes maybe. I believe yes, there is lag. There is lag. We're left with just 2-3 minutes maybe. Now, what is the treatment? If the serum calcium levels are more than 8 milligram per deciliter, no treatment. They are between 6 to 8. You have to give oral. If they are less than 6, you have to give IV, intravenous calcium gluconate, intravenous calcium gluconate. Yes. Fine. Now, more damage is suspected. Fine. That means you are sure that probably you have destroyed the parathyroid glands. Fine. In that case, you have to give calcium long. Fine. The next thing which they may ask you here is, just a minute, that what causes hypothyroidism? It is the vascular insult, that is spasm to the artery of parathyroid, spasm to the artery of parathyroid. Now, because we are running out of time, so the concept is that both superior and inferior thyroid vessels, now they should be ligated as close to the gland as possible. As close to the gland as possible. Superior should be as close to prevent injury to the superior laryngeal nerve. Inferior should be ligated as close to the gland as possible to prevent injury to the artery of right. Now, the next complication there is thyroid storm. So, if your patient has a thyroid gland which is bubbling with T3, T4 hormone and you take this patient for surgery, suddenly large amount of T3, T4 will enter into circulation. Now, what is the drug of in this condition? Propyl thiouracil. What is the most valuable drug? Propranolol. What can you do to prevent this condition? Lugol will make the gland firm and easy to handle during surgery. Easy to handle during surgery. Fine. Lugol's iodine. We can also use steroids. We can also use water bath to keep the patient cold, to keep the patient cool. Fine. Now, the severe complication are injury to external laryngeal nerve that will paralyze only one muscle, that is thyroid muscle, and patient cannot raise the pitch of his voice. Fine. The other complications are, you see, let's say keloid formation because doing surgery in the neck region. You know, the other complication could be stitch, granuloma, right? So these are the important complications there. These are the important complications there. Jyoti beta, thyroid storm. Can you draw the graph like this? Okay. So you see here. So here is hyperthyroidism. Years, hours. Fine. So hyperthyroidism, let's say normal levels. Hyperthyroidism is like this over a period of years. Fine. Thyroid Tom is like this. This. Over a period of hours, sudden rapid rise of the T3, T4 levels. Dr. Rahul, if I'm pronouncing your name correctly, my dear friend called Mango Shake. So it is like thyroid storm is a complication of thyroid surgery, but this can occur even during stress, this can occur even during illness, this can occur even during trauma. Fine. Now, that is what I wanted to tell you all about the thyroid. Now, I'll suggest, rather I will request that please do ask your queries so that I can answer them. Please do ask your queries. That is the most important part of the lecture, of you asking queries. So are you guys kind of overwhelmed? Yes. Dr. Rocket, no, because we did something like rapid revision kind. We did something like rapid revision. So I need to explain everything in details. We did this in less than 2 hours. So if I teach in the class, I'm going to take around 4-5 hours minimum. We did this at an extremely fast pace. Mithila bete, thyrotoxicosis are the clinical features which you see. Let me just tell you what all do you see. Mithila beta, listen to, look at your screen. So this is all. This is all what you see in thyrotoxicosis, the clinical features because of hyperthyroidism. Kushal Rathor, beta, you are much more precious than anything else. You're much more precious to us than our time. Yeah, Hashimoto thyroiditis. Hashimoto thyroiditis, it was the first autoimmune disease to be discovered. There are autoantibodies. Now, because of inflammation, the thyroid follicles, they will rupture. So that means large amount of hormone will be released into circulation. Suddenly, your patient will become hyperthyroid. Then what will happen? The thyroid gland will stop functioning. Fibrosis will develop. So then your patient will develop hypothyroidism, which will be prolonged, So the treatment will be, you have to give steroids, you have to give thyroxine to your patient as a part of replacement. Yes. Dr. Saif Shah, if you know that you have injured a nerve, it should be immediately repaired. Primary repair is the treatment. Dr. Hashim, could I answer your query? Mango Shake, bro, what is your question? In True Capsule, you told the veins are removed, so vascular system is removed. No. Hashim, see here, buddy. Hashim, see. Let's say this is the false capsule. Let's say this is the true capsule, and let's say this is the thyroid gland. There are millions of veins here. When they come out of the true capsule, they become one vein. They become one vein like this. So total 6 veins are there. Now let's say this is your scalpel. You cut the false capsule. Fine. Now, what is the best thing to do? Apply a ligature here, and cut in between. You cut in between. That is the best thing for you to do. Fine. Rather than you open this true capsule. See, buddy, believe me, as soon as you open the true capsule, there will be uncontrolled bleeding. Every place will be full of blood. So you don't open the true capsule at all. Thank you. Nancy, I hope you guys don't mind me calling you by your names. Fine. So you see, whenever there is increase, decrease TSH. We'll decide, Dr. Katir. Thank you so much, buddy. Thank you so much. We do. Raghu beta, were we too fast there? I'm really sorry, buddy. That's been my problem for ages now of running against time. I'm still here waiting for your queries. आई थिंक वी आर डन. मैं बस बच्चों का क्वेरी ले रहा था और बच्चों ने बता दिया कोई क्वेरी पूछ रहे हैं कोई नहीं पूछ रहे अभी. थैंक यू buddy. I'll be back with you. Right, buddy. So, sir is busy. So, maybe we'll get to see you whenever sir asks me to. Fine. I would be extremely glad to be with you whenever I get the opportunity. Right. So, as of now, good night. Really hopeful to see you guys soon, yet again. Thank you. And yes, definitely all of you will pass. Fine. All the best, buddies. Good night. Yes.